The following podcast is part of a certified educational activity titled Echoing Innovation in COPD, Transforming Patient Care with the Use of Targeted Biologic Therapy. Access the entire activity and complete the post-test at peerview.com/FTW860. Downloadable slides and practice aids are also available.
Hello and welcome to this educational activity. It's titled Echoing Innovation in COPD, Transforming Patient Care with the Use of Targeted Biological Therapy. I'm Fernando J. Martinez from UMass Chan Medical School, and joining me in this activity is my longtime colleague, Melan Han, from the University of Michigan Medical School. The goals for today are broad, and we have four key goals that we want to be able to achieve. We want to be able to get a sense of the underlying role of type 2 inflammation in COPD and how this provides a strong mechanistic rationale for the use of biological therapy in appropriate patients. In that respect, we're going to provide you with some clinical evidence that supports these T2 inflammation targeted biological strategies, demonstrating effect in selected patients with COPD. We will highlight that there are individuals with COPD who have elevated eosinophil counts or other treatable traits that may benefit from biological therapy, sort of precision targeting. In that respect, we will try to provide at least our sense of what a personalized team-based care plan involves, integrating biological therapy, shared decision-making with the patient and their caregivers, with the goal ultimately being to improve outcomes and making sure that those outcomes are aligned with patient goals and their preferences. That's a lot to do in this period of time. So again, I'm Fernando Martinez. I'm Vice Chair of Clinical and Translational Research. I've been involved in COPD investigation for a very long time. There is a robust evidence base estimating the impact of COPD now and how that's going to increase over time. For example, the World Health Organization estimates that by 2060, there'll be more than almost 5.5 million deaths occurring per year attributed to COPD or related coexisting conditions, sort of the multi-morbid patient. And we still have a situation in the COPD space where we fully appreciate that exacerbations, regardless of their severity, are associated with many of the bad things that we associate with COPD. That includes impaired quality of life, hospitalizations, risk of death. And interestingly, despite having an excellent range of inhaled triple therapy, so that's long-acting beta agonist, long-acting antimuscarinic, some long-acting bronchodilators, and an inhaled corticosteroid, a really big chunk of patients continue to experience these exacerbation events. And so, for example, these are just some of the data that provide you some sense of this component. These are data that suggest that in groups of patients that are taking a potent inhaled triple regimen, so despite that triple regimen, half of these individuals had experienced at least one exacerbation. And in this modified intention to treat, 60% of these people had experienced an exacerbation. So that despite having really good inhaled therapies, and this is like state-of-the-art inhaled triple therapy, patients are still having events and they're having repeated exacerbations. So this sort of highlights part of the reason that there's such a push in the COPD space to understand the importance of exacerbations despite our current therapeutic approach. There has been a long argument that's been made with these kinds of diagrams, like the one that's on your screen, that have linked these exacerbation events to multiple components of what has been considered progressive disease in COPD patients. And so when you look at this diagram, and there are multiple versions of this is just one of them, that suggest that these exacerbation events have been linked to worsening lung function, have been linked to decreased activity deconditioning, impaired mental health, depression, anxiety, associated with worsening quality of life, leading to, once you have events, you have more risk to have more events. You start that whole cycle again with eventually having a higher mortality for patients that had these exacerbation events. And each one of those links has been shown in multiple different cohorts. So this is not a hypothetical diagram. These are well-known relationships between exacerbations and each of those events. All of those not only impact the patient, but it impacts the patient and their caregivers. And so exacerbations really continue to be a critical focus for our management of patients with COPD. When you dig into the data a bit further, you get some additional insights regarding exacerbation burden and really sort of the overall impact of COPD on patients. So, for example, in numerous studies, airflow limitation, the key feature of COPD, associates with breathlessness, such that you have large portions of people who have exertional limitation. Patients may require oxygen therapy. That's associated with a whole series of additional components. A key area of interest right now in the COPD space is the fact that patients with COPD frequently have multimorbidity. And so the middle is an example of the frequency with which we see cardiovascular disease. That includes ischemic disease, coronary disease, but it also includes heart failure, high frequency of diabetes. They're all interrelated. And in fact, exacerbations interact with each one of those. And exacerbations are clearly associated with worse outcomes in patients with COPD that have underlying cardiovascular disease. The other area that's really of interest has been more recently highlighted in the asthma world, but now has spilled over into the COPD space, is the fact that given exacerbations and the limited treatments that we have for exacerbations, the oral steroids are used a lot. And so when you look at that right-hand side, I mean, it's a pretty good chunk of people with COPD that at some point have received an oral steroid. And what's interesting, and so again, this sort of started in the asthma world and has moved into the COPD space. This is this really lovely UK data set that has looked at a ton of individuals in the COPD space. They have this has a really lovely data set. And the analysis here was to try to get a sense of the frequency with which oral steroids were used in COPD patients, sort of matched to a different population that had not gotten steroids, and to try to provide some kind of a link between steroid use and a whole series of bad things, bone abnormalities, including fractures, vascular disease, type 2 diabetes, mortality. And the right-hand side shows that they have suggested a link between oral steroid use and all these bad outcomes. Now, this doesn't mean that steroids are causing everything, because this is not really a study that allows you to define causation, but it does give you a sense that exacerbations in general and how we treat them now, are including oral steroids, are associated with a whole bunch of bad things. And so it should not surprise you then that what I'm showing you in the slide is the latest version of the GOLD therapeutic strategy. We released this in mid-November 2025. And we spent a lot of time going over this. And what I'm showing you here is what we ended up deciding was the modifications for the assessment schema for patients with COPD. Milan will touch on this a little bit more. The way that we define airflow obstruction hasn't changed. It's spirometry with a ratio less than 0.7, severity of airflow obstruction by the GOLD staging, the GOLD grading, that's all there. What really changed is on the right-hand side. And that is the ABE schema, which takes into account two components in our COPD patients. So it's a multidimensional assessment. The first is exertional limitation. That hasn't changed. That's the bottom right-hand side, which is the symptoms with either the MMRC or the CAT score. So AB reflects more symptoms in the B category, less symptoms in the A category. That remains the same. What changed significantly is that exacerbation history per year. And we acknowledged in the GOLD therapeutic strategy that COPD should be viewed as an illness whose goal is zero exacerbations. So the goal is to have none of these events. And we have acknowledged that just having had one of these events in the last year increases your risk of having more events. And so that's a significant change in the GOLD strategy. That one or more, lowering that threshold to just one event is a crucial move by GOLD, and it acknowledges what I've shown you in all those previous slides. Exacerbations are bad in the COPD patient, and they're associated with many of the bad things that we associate with COPD. And managing those events, and ideally minimizing those events, is a key component. right? So as you think about that and contemplate COPD and the pathophysiology of COPD, which has a lot of inflammatory components, macrophages in the peripheral airways, activated neutrophils, lymphocytes, all of these inflammatory cells have a strong interaction and are associated with what we view in terms of this exacerbation-prone group of patients. The last bullet here is really where the field has evolved. We always thought COPD was neutrophilic, and it is in the vast majority of patients. But it's also clear that as many as 20 to 40% of patients actually have an eosinophilic inflammatory pattern, and so have this type 2 inflammatory pattern. So when you look at this next slide, the major modification of this type of a schema, which links to COPD with lung function abnormalities, symptom worsening, all of those components that I've mentioned to you before, including linking on the upper left to comorbidities, is where all of this type 2 inflammation may be linked, because type 2 inflammation and COPD has been associated with worsening lung function. It's been associated with increased risk of exacerbations, including the need for hospitalization. Therefore, in those links, they've been linked to mortality. And so type 2 inflammation becomes a key link for us as we're trying to assess the underlying biological processes in COPD and how they reflect to exacerbation. So just take a brief look at this 3D animation, because you'll sort of get an interesting and clever approach to looking at the type 2 inflammatory pattern in a select group of patients with COPD.
Type 2 inflammation is driven by both the adaptive and innate arms of the immune system and underpins the pathophysiology of several chronic upper and lower airway diseases, including asthma, chronic obstructive pulmonary disease, or COPD, chronic rhinosinusitis with nasal polyps, and allergic rhinitis. Some studies have shown ranges of 20% to 40% of patients with COPD may have type 2 inflammation, which may increase exacerbation risk. Mediators of type 2 inflammation include eosinophils, mast cells, Th2 cells that produce the cytokines IL-4, IL-5, and IL-13, ILC2s, and IgE producing B cells. During an immune response, IL-4 and IL-13 play an important role in the class switching of B cells to produce IgE and drive the trafficking of eosinophils to sites of inflammation. Mast cell proliferation is promoted by IL-13. IL-5 mediates the differentiation of eosinophils in bone marrow. In some patients with COPD, eosinophils trafficked by IL-4 and IL-13 can be recruited to the lungs, contributing to airway remodeling and parenchymal destruction. Airway remodeling can lead to airflow limitation, resulting in symptoms such as shortness of breath, and increased mucus production, which obstructs the airways and makes it more difficult to breathe. Parenchymal destruction leads to reduced surface area for gas exchange and decreased lung elasticity, making it challenging for the lungs to efficiently expand and contract during breathing.
All right, now that you've gotten a sense of this type 2 inflammation, the key component for us now is, all right, so what? What is the implication of that from a therapeutic perspective? So this figure is sort of a narrowed version of a very complex schema for inflammation in COPD, but it's focused on key pathways, key cellular constituents that are driving this type 2 inflammatory picture. And most importantly, you look at where there are therapeutic targets that are either in development or have already been developed. So the bottom right-hand side, which is sort of more distal, is really targeting inflammatory cytokines that drive this type 2 inflammation. That includes dupilumab, which targets the IL-4 receptor, so IL-4, IL-13. A little bit lower to the left side, you see drugs that target IL-5, the IL-5 receptor, that's Mepo and Benra. Those are really targeting IL-5. And if you look at the effects of those inflammatory cytokines, it drives a lot of this type 2 picture. In addition, if you look higher up, there's a lot of activity right now. We'll talk about some of these as we go along, targeting sort of more upstream, including targeting alarmins. These are pathways that the epithelium has to respond to injuries. whether they're injuries that reflect infection, viruses, bacteria, whether it's inhalational stress, all of those components. And the ones that I want you to focus on are those that are targeting IL-33, one of these alarmins, because all of these are in clinical trials, and those that are affecting TSLP, TSLP, that also is in clinical trials. So the reason that this understanding this type 2 inflammation is so important is that it has clear ramifications in the biology of COPD. It is linked to the biology of exacerbations, which are bad things for our COPD patients. And they are all either now therapeutically appropriate to target or soon will be even more so therapeutically targeted. It is important to understand that the biology of COPD, including understanding type 2 inflammation and IL-5, IL-4, and IL-13, those components are crucial in our patients because these inflammatory pathways are clearly associated with a series of the biological effects that we know are seen in our COPD patients: airway hyperreactivity, abnormal epithelial function, and clinical manifestations, including mucus and mucociliary dysfunction, sputum production, all of those components, all of which are relevant to exacerbations. And so it is really important to have a really good sense that COPD is, in fact, a progressive disease. Exacerbations are key components of that progression. Type 2 inflammation in 20 to 40% of patients, for which we have a really good surrogate marker, circulating eosinophils, easy to measure. That complex interaction in COPD of type 2 inflammation, exacerbations, is all now relevant because it is biologically targetable with therapies that we have in our clinic. I'm going to have Meilan now sort of give you a sense of exactly what I mean by that latter point.
All right. Well, thanks so much, Dr. Martinez. My name is Meilan Han, and I'm a professor of pulmonary and critical care medicine at the University of Michigan. And I'll be chatting next about an individualized approach to type 2 inflammation-driven COPD care. So when we look at the most recent update to GOLD 2026, we'll see that the groupings or initial treatment recommendations for COPD are the same as last year. We've still got a group A, a group B, and a group E. However, the way that risk is assigned is a little bit different in that GOLD is recommending that we start being concerned about increased risk for exacerbations with one moderate or severe exacerbation in the prior year as opposed to two. So this is a little bit new, and I think really helps to emphasize that even one exacerbation is one too many. So that is a little bit of a frame shift for us, I think, as physicians. But the initial treatment recommendations for Group A, Group B, and Group E do remain the same. So this, again, is just general recommendation for all patients. But if you have a Group A patient, so that's low symptoms, low risk of exacerbation, a bronchodilator, really any bronchodilator is fine. For Group B, they are recommending a dual bronchodilator with long-acting beta agonist along with a long-acting muscarinic antagonist. And this is for patients, again, with no prior exacerbations in the last year, but with an MMRC of 2 or more or a CAT score of 10 or more. And then for patients who are at increased risk for exacerbations, they've had an event in the prior year, regardless of symptoms. Again, the recommendation is dual bronchodilator, but possible consideration for starting patients on triple therapy that includes an inhaled corticosteroid if the patient has a blood eosinophil level of 300 or more. So this is where this discussion of type 2 driven inflammation comes in. The first place we see it here is in the recommendation for potentially starting patients on ICS again as initial therapy with COPD. Now, for follow-up treatment, there have again been some slight modifications and updates to GOLD 2026 as opposed to GOLD 2025, and I will point out to you where those are. So first, if we think about patients who have shortness of breath, if they're only on a single bronchodilator, we want to move them up to dual. And if they're still short of breath, this is where you double check that you make sure they're using their inhaler correctly. You could consider, switching either device or molecule. But another thing that was new in last year's update is that we do in the U.S. now have ensifentrine available, which is a PD3, PD4 inhibitor nebulizer, which does improve lung function and can reduce shortness of breath. Now, where we see a change in this year's update is on the exacerbation side. And again, this is, again, focusing on the type 2 inflammation. So generally speaking, if patients have high eosinophils, we progress them from a single to a dual bronchodilator, and then up to triple inhaled therapy. But the kind of new piece here is that if patients have blood eosinophil counts of 300 or more, we now have 2 FDA-approved options for treatment of patients who persist with exacerbations. And that includes dupilumab for patients who also have chronic bronchitis. And the new one is mepolizumab. These are both options for us. Now, if you have patients with really low eosinophils and they're still having frequent exacerbations, roflumilast is something that can be added. Most helpful in patients with chronic bronchitis and low FEV1. And then azithromycin is another option, regardless of eosinophil count, that probably works best in former and not current smokers. So we do have some options: roflumilast, azithromycin, dupilumab, and mepolizumab if patients are still having frequent exacerbations. But again, the dupilumab and the mepolizumab are really the ones that we're looking at for patients with higher levels of eosinophils. So if we want to dig into some of this data just a little bit more, since some of these medications are relatively new, and I know some people may not be familiar with all of the data. First, I want to talk a little bit about ensifentrine, which I mentioned. So ensifentrine it's about, I think, approved a little over a year ago, maybe a year and a half. It is a PD3, PD4 inhibitor. It's nebulized, and the 2 pivotal trials that led to FDA approval are the ENHANCE-1 and the ENHANCE-2 studies. Both studies show significant improvements in FEV1, and both showed improvements in 2 measures of symptoms. The mean ERS and SGRQ scores were improved in the ENHANCE-1 study primarily, but both studies showed reductions in exacerbations, which is interesting because the studies actually were not designed to show reductions in exacerbations, and so they, did not necessarily recruit a high-risk patient population. The other thing which has made it difficult to figure out where to place ensifentrine on the GOLD diagram and really ultimately led to it being placed on the dyspnea side of the diagram is that these patients were on a broad variety of background therapies, but not really including triple inhaled therapy. So we don't really know if there's additional exacerbation reduction on top of triple therapy with ensifentrine, but at least for on top of a variety of dual inhaled therapies, there was a reduction in exacerbations, which I think is interesting. But primarily, the drug was approved based on its bronchodilator effect. So what are some of the shortcomings of our current pharmacologic approaches? Well, first, a proportion of patients with moderate to very severe airflow limitation, unfortunately, do still have exacerbations despite having optimized standard inhaled therapies. Some patients with high eosinophil counts will still have exacerbations despite triple inhaled therapy. Again, one of the challenges with the inhaled therapies is they may not specifically target all of the key type 2 inflammatory mediators, which is why it's, nice that we do have some of these newer targeted biologics now available. And this really goes back to the discussion of how precision medicine in COPD has evolved. Ideally, we would be able to tie phenotype, which are the clinical features we see with underlying endotypes, and very specific biologic pathways to guide treatment decisions. And I think the type 2 inflammation story in COPD is just sort of the first of hopefully many examples where we'll be able to target very specific endotypes in COPD we're really starting to have some, I guess, treatable traits would be the best word for it. We can focus on either shortness of breath, we can focus on exacerbations, and then within this exacerbation bucket, we're starting to develop some sub-buckets, things where things like chronic bronchitis, eosinophils, and smoking status all help to guide therapy. So we do have some emerging biomarkers, as I pointed out, that can really help us to kind of identify who these specific patients are that might benefit from these targeted therapies. Some of the biomarkers that are currently being investigated include blood eosinophil counts. I showed you that those are now incorporated into GOLD and help to predict enhanced response to corticosteroids, as well as some of the targeted type 2 anti-inflammatory biologic agents that are now approved in COPD. FeNO, while it's not in the GOLD update, there is clinical trial data to suggest that it may also be helpful for identifying subgroups of patients prone to exacerbations and who may also benefit from both inhaled steroids as well as targeted biologic agents. And then IG, I think, is still kind of being investigated. We do know it can be associated with increased frequency of exacerbations, particularly in men, as well as increased risk of lung function decline. So when we think about eosinophils more specifically, we know that higher levels of eosinophils are, particularly in the blood, are associated with increased eosinophils in the lung, as well as probably, interestingly, lower rates of the presence of bacterial and bacterial overgrowth and pneumonia. But they are also associated with more, with higher increased frequency of exacerbations, as well as, at least in some patients, lung function decline. Now, when we think about FeNO, some people may be a little bit less familiar with this. I think it's becoming increasingly available, but may not be available in every practice setting. But there is a strong correlation between FeNO levels and blood eosinophil counts in patients with COPD, so that I think is important to know. And we do know that there's an association between FeNO and COPD with respect to clinical outcomes. So in one particular study, they demonstrated that the higher FeNO is associated with increased risk of exacerbations, hospitalizations, and even death. So I think one of the challenges that we have as physicians is trying to identify which patients are going to be at highest risk for exacerbations within our practice. We know, generally speaking, patients with lower levels of lung function are at greater risk, but that doesn't mean that patients with mild to moderate airflow obstruction can't also have exacerbations. And I think the same is probably true with dyspnea, as well as quality of life scores like coming from the CAT. We also know that structural and functional abnormalities, in particular bronchiectasis and poor mucus clearance, can also help to identify patients at increased risk for exacerbations. Other things that people have identified include increased bacterial colonization, immunoglobulin deficiencies, other related disorders, including things like reflux, and then both blood and sputum eosinophil counts, as we had discussed. So when thinking about trying to identify patients that might be good candidates for type 2 anti-inflammatory biologic therapies, first, we know they have to have a diagnosis of COPD. We need to optimize standard therapy, which is usually going to include triple inhaled therapy. Look for continued exacerbations despite that. Assess for presence of type 2 inflammation, where I think blood eosinophil count is a primary thing to assess, but FeNO can also help. And at that point, consider biologic therapy for patients who kind of meet this criteria and show evidence of type 2 inflammation and persistent exacerbations despite optimal inhaled therapy. So at this point, I'm going to turn it back over to Dr. Martinez.
All right, great. Thanks, Meilon. So that's very helpful in putting this within context. Now it's important for all of us to see how we can move this into something that we can do in our clinic. And how is selecting a biologic therapy important in our patient with COPD. What's the right person? What's the right timing for us to consider this type of therapy? Okay, so I'm going to take you through some of the literature. I'm going to take you in historical sequence so that you get a sense of why we are where we are now. The first of the studies targeting COPD with a biologic were mepolizumab, which, remember, you saw it earlier. That targets IL-5. It's very effective in asthma, revolutionized asthma therapy. So the early studies with mepolizumab were mixed. And so there were two key studies published 7-8 years ago in the New England Journal of Medicine, Metrix and Matreo. They're on the left-hand side. One clearly looked like it was having an effect. The other one was not so much. So the right-hand side then was a pooling and analysis of these to try to get a sense as to what had happened. And the suggestion at that time was that it may be that the thresholds were not appropriate in the COPD population. And that the higher the eosinophil blood count, the more likely you were going to see an effect that favored mepolizumab. And so that was a strong suspicion. Okay, it may be that in COPD, we have to readjust in our minds what the threshold is. In asthma, it's very clear. 150 clearly is an asthma well-established threshold. At around the same time, benralizumab, also very potently targeting IL-5, published two studies. So it's a couple of years later, not even 2 years later. And there were Galathea, Terra Nova, again, mixed results between the two studies. So we were like, oh, man, here we go again. It's not quite as dramatic as it is in the asthma world. A sub-analysis, a pooled analysis of these data, shown on the right-hand side, suggested that, you know what, these drugs may have a benefit, but you have to really consider who is the right person. And this particular plan suggested that it was in part the eosinophil count and a clinical feature, the prior history of events. And so that became the pattern of thinking, that it may be that in the COPD population, it's more important to really think about the optimal patient that you would want to use a biologic. The revolutionary data came from the dupilumab study, which, remember, targets the receptor. It's IL-4, IL-13. But this group actually took a higher threshold for eosinophils. They said, we really want a COPD population that are chronic bronchitics and have an eosinophil count greater than 300. And they did two studies in parallel, Boreas and Notice. This is a pooled analysis of both. It's important to realize that this dramatic improvement in exacerbation rate was duplicated in both of those studies. They were almost identical in terms of how positive they were. So this was revolutionary in our space because it highlighted that in an at-risk population, these are people that had predominantly been on triple therapy, but had had prior exacerbations despite that. If they had an eosinophil count that was greater than 300, you could, with a biologic, dupilumab, drop exacerbation rates in this high-risk population by more than 30%. Again, confirmed in both of those studies. This is a pooled analysis. It also improved lung function. Again, in the studies and in the pooled analysis. And it also improved quality of life. The adverse event profile, again, here it's sort of pooled data, was the same as you expect with dupilumab, which has been approved in a whole bunch of indications, been used in kids for eczema, for example. And so it was clear that with these dupilumab studies, if you targeted type 2 inflammation in an appropriate patient population, recurrent exacerbations, despite maximal inhaled therapy, with an appropriate eosinophil count, absolutely dupilumab had a dramatic and reproducible beneficial effect. That was impressive, and it was the first biologic approved in the US and in Europe for COPD. So we also did the same with mepolizumab. We went back and looked at the original data and said, what if we really look at a higher eosinophil count, greater than 300 at screening, and targeted a patient population with recurrent exacerbations despite being on a maximal inhaled therapy, but with that higher eosinophil count? What would happen? Here it is, the results of the matinee study that we published earlier this year in the New England Journal of Medicine. You could decrease exacerbations, including severe exacerbations. And this was a broader population because it included chronic bronchitis and non-chronic bronchitis. It didn't have quite the same effect on quality of life or lung function, but it clearly had an effect on exacerbations. So the field then said, all right, that's the second biologic that with a difference in terms of the eosinophil threshold suggested that, in fact, there's a patient population with COPD at risk for exacerbations that need a biologic. And so it also approves. And now you have two biologics targeted in this type 2 inflammatory process in the COPD space. And MEPO's been around for a long time. The safety profile was the same as we've seen in other indications for epolizumab. So this was really fantastic. This was revolutionary for us. We in the GOLDS therapeutic strategy had to put all this together to try to make some recommendations. I think Milan will give you a better sense of that. So this is really sort of a general summary that we included in the most recent GOLD strategy, sort of comparing the DUPI studies on top, the MEPO studies in the bottom. Both clearly had effects on exacerbation rates. The effects on quality of life and lung function were less consistent between the two drugs. The patient populations were a little bit different. The severity of the patients were a little bit different. The presence of chronic bronchitis or not. So it's really hard to make head-to-head comparisons of both of these drugs. Suffice it to say that in an appropriate patient population, you see it in that key inclusion criteria. That is, eosinophils, history of exacerbations, despite being on maximal inhaled therapy. Both of these drugs had an effect, with the DUPI studies showing a little bit more robust effect than some of the other endpoints. As I mentioned briefly earlier, one of the advantages to both of these drugs, they've been around for a long time, and they've been used in a lot of people for multiple indications. And so, in fact, part of what we now use in clinic to try to decide one agent versus the other, it's what the payer is going to allow you to do, what the patient wants to do in terms of how frequently they want to dose, but also the underlying potential of having other comorbid conditions that may lead you one way or the other in terms of choosing one versus the other. But these are both drugs that are now approved to be used in the COPD space. I mentioned to you earlier in one of the earlier slides that this is an incredibly active field right now in the COPD space, because not only do we have positive results for two biologics specifically for that type 2, but we now have a series of biologics that are targeting other pathways, including higher up in the inflammatory cascade, these alarmins. So here is one of those. This is itepekimab, which is targeting the IL-33 process. So it targets the cytokine. And we finished two different studies, AERIFY-1, AERIFY-2, the multiple large studies, dose ranging, and so on, in a patient population that had risk of exacerbations because they had recurrent exacerbations despite being on inhaled therapy. And one of the key things here was that the eosinophil criteria was not a big driver, because this is higher up in the inflammatory pattern where the eosinophil threshold was not felt to be as crucial. The disappointment to this was that, this is a press release, unfortunately, I was the global PI of AERIFY-1, so I've seen these data in graphic detail. I can tell you that AERIFY-1 was positive, no doubt about it. You saw reduction in exacerbation rates, multiple secondary endpoints, independent of eosinophils. AERIFY-2 was positive up until week 24, and then we lost a lot of the effect. We're still trying to figure out why that happened. So that was disappointing that we couldn't completely replicate it. My own bias, and I have a conflict here, is that IL-33 targeted therapies are going to have an effect. This needs to be reproduced. At around the same time, there was a different program that was targeting the same pathway, but a little bit lower down in terms of the actual approach to targeting a slightly different version of IL-33, but this is still IL-33. It was anti-ST2, which is part of that pathway. And so again, it was the same thing, large study, 2 doses, in a similar patient population. At the European Respiratory Society meeting in September 2025, results were presented, and it was sort of the same. One study had a 15.5% reduction, met the endpoint. The other one almost did, but didn't quite reproduce it. So we were again in the situation of, Lordy, it is clearly likely something to this IL-33, but it's not ready for prime time yet. And the safety profile was good. I mean, I think this is all suggested to me. Again, I'm biased because I've been working on these programs, that IL-33 is something you'll be dealing with in clinic. It's just not going to be in the immediate future, with the only caveat being that there is a separate IL-33 program, tozorakimab, that has completed a phase 2 study. That's here. It wasn't positive, but it had suggestion that it could have an effect on lung function and potentially on exacerbations. And this group has been really aggressively using these data, which is sort of a surrogate of potential exacerbations in this small phase 2 study, to design these trials. I mean, these are the largest trials of an IL-33 in the COPD space. So there are these 2 large multi-dose studies, again, at-risk patients with at risk for exacerbations on inhaled therapy with 2 doses of a drug that really is targeting the cytokine. And they will read out early this next year. And so you've got both of these studies in the IL-33 space with an additional study that also has a longer period of time of follow-up. So these are massive studies. And guys, these will all read out early next year. I don't know what they're going to show. I'm hopeful that they will show that targeting IL-33 is beneficial because, again, as I mentioned earlier, with both the astegolimab and the itepekimab programs, that there is something here when you target IL-33. Targeting alarmins is going to have a benefit in a patient population. We'll see when these studies all read out. And I think part of the complexity for us will be trying to decide at what point and for which patient. I hope we have that problem that we have to deal with when we're going to use Dupi versus Mepo versus when we're going to use one of these, because that means we have a lot of potential activity that'll benefit our patients. Remember where I mentioned to you in an earlier slide that at the alarmin level, there are multiple alarmins. The 2 that are being targeted right now are IL-33. I showed you those 3 programs. And the TSLP study that is farthest along is this tezepelumab, approved in asthma, has had dramatic effects in the asthma space. This was a phase 2 study. The phase 2 study was, again, not robustly positive, but there were enough signals in terms of exacerbation reduction that a large phase 3 study is ongoing with this TSLP. Again, when we repeat this type of a program in a year, maybe 2 years, it's going to be a lot more complicated because it's going to be multiple biologics for individual patients. Because the question for us is going to be what is the patient for each of these? So we got to define the population of patients. Is it based on just a biological marker? Is it based on a patient characteristic? And I can tell you that there are studies right now being designed and starting that are targeting earlier institution of these therapies, that are targeting disease modification with these therapies. And there are actually studies that are using these for acute events to see if we can modify. In fact, there was one with Benra study that was published recently with that. And so it is going to be not a bad thing, a good thing, a complex field for us, because biologics clearly have a benefit. We right now know the patient population in whom type 2 biologics, dupilumab, mepolizumab, are most likely to have a benefit. And so those we clearly understand now will reduce exacerbations in a well-defined patient population. It is going to be more complex as particularly the IL-33s come in, but hopefully the TSLP as well. The asthma space is very complex now. There are multiple different biologics. These are all being used in asthma. And it's become challenging for my asthma colleagues to try to really figure out exactly where to position these. That is going to be COPD. That is not a bad thing. That is a good thing because it shows how much we've advanced. And I'm going to turn it over now to Meilan, who's going to give you a little bit more insight that's a little more practical in how to consider these. Meilan?
Okay, so now let's talk about practical considerations for targeted biologic therapy in COPD. So what are the goals of treatment when we think about our patients with COPD? I think we want to reduce symptoms, we want to reduce risk of exacerbations, but ultimately we'd love to also prevent disease progression. And I think the hope is that by improving symptoms and reducing exacerbations, that ultimately we would be able to modify the course of the disease. When we think about symptoms, this could include cough, shortness of breath, but it might also include things like exercise tolerance. And when we think about risk, I think we usually focus primarily on exacerbations, but I think, risk for hospitalizations as well as death is also part of that consideration. So it's important, although I will admit, I think increasingly challenging in today's healthcare environment, that we think about multi-directional, multi-specialty communication and collaboration of patient care. So it is the minority of patients who only have a lung problem. The most have probably multiple specialties involved in a patient's care at a minimum. That's going to be primary care, but it could also involve advanced practice providers, respiratory therapists, allergy and immunology, as well as a variety of other specialties with things like, for instance, cardiology or endocrinology. So this, I think, can be very challenging, but probably in today's environment, even more important than ever. When we think about what we think is important with respect to patients versus what they think is important, I think it's important to realize that those goals may not always be perfectly aligned. And when we look at studies that have asked patients what their priorities are with respect to treatment goals, the number one priority is actually elimination or reduction of symptoms. Particularly among newly diagnosed patients, as well as ability to socialize and exercise. At the time of diagnosis, preventing flare-ups may not be their primary priority. As time progresses, however, and patients get worse, that does become a bit more of a priority moving forward. But as we start to have discussions with patients about what's important to them and what their treatment goals, this is a place where the concept of shared decision-making becomes really important. And it's something I think in medicine that we talk about a lot, but in reality, it can be challenging to actually live out in practice. But in an ideal world, we would provide patients with facts and treatment recommendations, but they would also then express back to us their values and preferences, and that would shape, again, our treatment recommendations, where it's sort of this back and forth process to get to an ultimate decision. So when we've got patients in the office and we're trying to decide, for instance, should we escalate to a biologic, we want to start by reviewing overall symptom control, exacerbation frequency, quality of life, and then talk to patients about what improvement would look like for them, what they think that they would like to be able to do if they were either less breathless or have fewer flare-ups, and then explain to patients what the medication is, and that the primary goal is to reduce the frequency of flare-ups. I think it can be a little bit challenging in COPD because most patients are used to taking things like albuterol, where they feel immediately better. And they assume if they aren't feeling immediately better, that the medication's not working. Biologic therapies are going to be different. We hope the patients feel better, but they may not feel better. And the primary goal really is exacerbation reduction. And so in some ways, it's almost like taking an antihypertensive. It's something that definitely works. It's important. But just because a patient doesn't notice some immediate symptom improvement the second they take it doesn't mean it's not working. So there are also safety concerns and costs and duration of treatment that also need to be discussed. But injections are definitely not something that's been in the COPD world. Patients with asthma, we've had biologics on the scene a bit longer, but for patients with COPD, this could be something new. But fortunately, there are pre-filled syringes and pens that can be used at home. But talking to patients about side effects, including soreness at the site, and that this is not something that's going to be working immediately. We need to talk to them about checking in every few months. And then the importance of at least getting the baseline blood work to check for eosinophils. There is no ongoing, it's important to know also from a provider perspective, there really is no ongoing lab monitoring needed for either of the two biologics approved for COPD here in the U.S. So as we continue this discussion, with patients. Again, it's important to emphasize that the goal of the biologics is to reduce the frequency of flare-ups, but we would hope it would also improve patients' quality of life, primarily through reduced need for treatments for exacerbations, as well as sort of the quality of life setbacks that occur when patients have those. So just a couple other things to remember. If you're prescribing dupilumab, for instance, it's 300 milligrams every 2 weeks. There is no initial loading dose required for COPD. You want to allow the medication to come to room temperature before administering, rotate injection sites, and avoid going through scarred or damaged skin. Rarely patients can experience conjunctivitis or keratitis, which can be treated with cool compresses or over-the-counter drops. And if patients have a missed dose, if it's within 7 days, continue original schedule. If it's greater than 7 days, just go ahead and administer the dose, starting a new schedule based on the new date. For mepolizumab, this is the dosing schedule is a little different. It's 100 milligrams every 4 weeks, but kind of similar information with respect to where to inject, concern for site reactions. In a few patients, back pain has been reported, and it's important to feedback to the clinician if this is something a patient experiences. And in terms of missed doses, the recommendation is to inject a dose as soon as possible and resume injection on one's regular dosing schedule. And if a missed dose is not noticed until it's time for the next scheduled dose, inject as planned. So I think it might be helpful actually to go through a quick patient case just to kind of get a feel for how this could play out in the clinic. So we're going to start with Jack, who's a 62-year-old gentleman with COPD. He's a former smoker. He has a 30-pack-year smoking history and quit 10 years ago, but he's been managing COPD for the past 5 years on triple therapy. But his symptoms have worsened over the past 12 months. He has really persistent dyspnea with an MMRC grade of 3, a chronic cough, but he's also noticing some increased sputum production. And he's had about 2 to 3 exacerbations per year recently, and even was hospitalized for a severe exacerbation. His other medical history includes hypertension and hyperlipidemia. Now, when we do spirometry on him in the office, we see that his FEV1 is 45% predicted, so that's a gold stage 3. His CT shows both emphysema and bronchial wall thickening. His blood eosinophil count is elevated at 350, and his FeNO is also elevated at 40. Elevated, while there is some debate, is probably somewhere between 20 and 25 parts per billion would be considered an elevated FeNO level. So this patient definitely is showing signs of type 2 inflammation. He's already on triple therapy with salmeterol, tiotropium, and fluticasone, but despite adherence to triple therapy, is still having frequent exacerbations and poor symptom control, and really is reporting significant limitation in his daily activities due to shortness of breath. So this is a patient where I think biologic therapy is a strong consideration because he's having frequent exacerbations despite optimized triple inhaled therapy, and he has some of the important markers that we look at for evidence of type 2 inflammation, which would be elevated eosinophil count, in this case 350, and elevated FeNO, in this case 40. So he really is a candidate, and so this is where that shared decision-making comes in to kind of explain the potential risks and benefits of potential biologic therapy, particularly in reducing exacerbations, although there's also potential for lung function and quality of life improvement. He's somewhat concerned about the injection process, but reassured that these really can be done easily, both in the clinic or at home with proper training. And it's always an option to do that first injection in the office to give the patient, or multiple injections in the office, just to give the patient that increased comfort level with the process. So in this particular case, we discussed the pros and cons, and Jack decides to start a biologic therapy as an add-on to his current inhaled therapy, but will continue working on things like pulmonary rehab and smoking cessation to improve his overall lung function. So just kind of what are the key summary and takeaways from today's program? Just to remember that COPD is a progressive respiratory disease that can have significant impact on quality of life, and progressive lung function detriments, and that for some patients, type 2 inflammation plays a central role, contributing to frequent exacerbations and poor disease control. For patients with frequent exacerbations, particularly eosinophil counts of 100 or more, triple inhaler therapy remains a cornerstone of COPD management. But the need for targeted biologic therapy is real. And fortunately, for a subset of patients, those with type 2 inflammation, we do have two therapies, mepolizumab and dupilumab, which are currently available options. There are others that are in development, and there are also other treatments for non-type 2 inflammation that are also currently being examined. So it's, I think, a very exciting time for patients and providers to have some new treatment options and hopefully more on the horizon. So as we bring patients into the office, it's important that we emphasize to patients what's possible with these new medications and that they understand the goals of treatment, and that all this be done within the setting of a team-based approach involving both pulmonary, primary care, and other specialists to help manage COPD within the broader spectrum of the patient's illnesses. So on behalf of Dr. Martinez and myself, I want to thank you for listening, and we hope this activity was useful to your practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/FTW860.